I would like to tell about Shivangi. She's a wonderful senior resident in the department. Now she's assistant professor. And she does some surgeries which many of us would not be doing. She is a complete eye surgeon. She does anterior and posterior, all the surgeries. And she is daughter of my dear friend Dr. S.P. Singh and my Bhatiji Shivangi. Please.
Thank you, Sam. I am a good surgeon because I got a good guidance from my teachers, like you. So thank you. So I'll be talking about retropupillary iris claw lens. Starting with the introduction, these lenses have been increasingly chosen by surgeons nowadays because of their simple technique, favorable functional outcome, safety, and there is lesser learning curve in this, and they are economical as well. So the various options that are available nowadays are the anterior chambered IOL, the posterior inclavated iris claw lens, and the scleral fixation IOLs. The iris claw lens can be placed either anteriorly, but posteriorly is preferred because it is more anatomically in position. There is less risk of endothelial cell damage, anterior chamber is deep, and the iridocorneal angle is wider. So I'll be starting with the topic, which is the topic of my today, surgical steps of iris claw lens implantation. Starting with the first step. So to get the exact marking of the two side ports that we need, we can use this toric marker to mark 0 and 180 degree. And once the marking is done, we now make the side port. I would like to mention one thing about the side port, that the side port should be a single stab, and a short tunnel. So this short tunnel of the side port helps us to, for better manipulation and better maneuvering of the side instruments while we are enclaving the iris claw. This was a 4 weeks old case, so there was a sclerosed tunnel and also adherent iris tissue superiorly, which was released with the help of iris depositor. And we can use a triamcinolone to stain the prolapsed vitreous, which help us to better visualize the anteriorly prolapsed vitreous, and the anterior vitrectomy is then performed to remove all the tractions and to remove all the vitreous from the anterior chamber. Once the anterior chamber is free of all the vitreous and pupil is well round, the iris claw lens can be then placed inside under the air bubble over the iris tissue. It is then dialed so that the two haptics are at the vicinity of the side port. The air bubble is replaced with viscoelastic, and now the lens can be held from the center. It is gently slid below the iris tissue, and it is tugged with the help of a Sensky hook or any blunt instrument. So here we can see a nice tuck is seen where the enclavation has been made. So this confirms that the enclavation is proper and it will not come out. Similarly, on the other side, the haptic is gently slided below the iris tissue, and then the lens can be lifted up a bit so that we can see this indentation on the side, so that we know where the notch is, and then with a single click, we can just place the iris claw lens in place. And the pupil is well round and circular at the end of the case. This was another case of aphakia which was planned for secondary IOL. So here we did the the marking with a toric marker, but make sure we need not make such a prominent marking, because like we do in a toric lens, because this prominent marking will cause some hindrance when we go for enclavation with the through the side port. Following steps are the same. We do the vitrectomy, we clear all the vitreous, and then we place this iris claw lens under the air bubble. The reason we place it under the air bubble is it prevents the viscoelastic from trickling down in the posterior vitreous. Once the lens is placed and the pupillary area is covered with the lens, we can replace the air with viscoelastic. And now I have done a little slow motion to show one more small trick, that we hold this lens from the center such that the edge of the forceps is, this edge of the forceps is in inclination with the notch of the haptic. So this gives an indirect clue when we are beneath the iris It gives an indirect clue as to where the notch is and as to where we have to enclavate. So with just a single tuck, we can get a proper enclavation. Because if we do a multiple tucks, we may damage the iris tissue over there. So this simple technique helps us. Also lifting a lens a bit so that we can see that indentation for enclavation. Yeah. So now I would like to show some few cases. This first case was a traumatic anteriorly dislocated nucleus, and I observed that there was no capsular support beneath it. So I gently dialed the nucleus and then prolapsed it through the sclerocorneal tunnel. Once the nucleus is out of the tunnel, we now stain the vitreous with the triamcinolone and then do the anterior vitrectomy as discussed earlier. So anterior vitrectomy is important in such cases. After doing the anterior vitrectomy, we may use the pilocarpine to constrict the pupil further, and then the iris claw lens can be implanted in a routine fashion by simply tucking the first haptic followed by the other haptic. Instead of Singh hook, we can use this iris reposter spatula as well. This iris reposter spatula is helpful because it is a blunt instrument, so it is less traumatic to the iris tissue. But it depends on surgeon to surgeon what do they prefer, Singh hook or the iris spatula. The excess viscoelastic can be washed off. And yeah. So this was another case of inferiorly dislocated IOL lens. This was a PMMA lens. So luckily it was in the anterior vitreous only. So I took it out through the sclerocorneal tunnel with the help of a Singh hook. And following that, anterior vitrectomy is performed after staining with triamcinolone. So while performing anterior vitrectomy, make sure that the mouth of the cutter is faced upwards and always away from the iris tissue, because this will prevent to cause any iatrogenic damage to the iris tissue. There was some peaking superiorly, so because of the vitreous strand, so which was released with the help of iris spatula and then cut with the cutter. So our aim is to achieve a good round pupil before implanting the iris claw. Pilocarpine can be injected and followed by the iris claw lens implantation in a routine fashion, as we have already discussed. We can also pull the lens a bit to see whether the enclavation has been done properly or not. So, and this is a last case that I would like to show of phakia with the deficient posterior capsular support. So initially I planned to do a 3-piece IOL if I could get a good capsular support, but it was not a case. So I went ahead doing the anterior vitrectomy, and I had iris claw lens to my rescue. So after performing the anterior vitrectomy, we went ahead with the iris claw lens. Here I would like to emphasize that the sclerocorneal tunnel that we make for implanting the iris claw should not be more than 5 to 5.5, which is the diameter of the iris claw. So a small tunnel will do for iris claw lens implantation. So these are the small tips that we can use to implant the iris claw to prevent any complications that occur, like ovalization of the pupil or decentration of the IOL, or maybe late disenclavation. Some complications will be taken up in detail by my senior. So I'll just stop my talk here. Yeah. So if I have time, I'll just discuss, enumerate some of the advantages and disadvantages of the iris claw. So it is a simple technique. There is no suture required. There is easy learning curve, less time required, no tilting of IOL, very safe for corneal endothelium, and produces less glare. And because now we place it posteriorly, so the physiological space is there behind the iris. The disadvantages is it may cause iris atrophy in some patients, or late disenclavation if it is not properly enclavated, secondary glaucoma, lens decentration, and lens pigmentation. Surgical techniques I have already discussed, and These are some of the complications, like the iris atrophy. We do not put it in if there is iris atrophy, large iridectomy, or in uveitis cases. So to conclude, iris claw is clinically safe and effective secondary or primary procedure in cases with deficient posterior capsule or inadequate capsular support with minimal complication rate. So this procedure can be used in wide range of indications. Thank you very much. So, so I'll just request my sir, from whom I've learned a lot, Professor Kamaljeet Singh sir, to present his talk. Thank you.